We have a saying in emergency medicine that sometimes it's better to be lucky than good, and my ego has no problem with luck getting us to the diagnosis rather than my intelligence. It was a really busy night. I was in single coverage, which means I was the only attending physician. I had a resident physician and a PA that I was working with, so we had a great team. We were churning and burning, but it was busy. I read the triage note for a patient that sounded like slam dunk classic appendicitis. Generalized pain that then moved down to the right lower quadrant, lowish grade fever like 101, and didn't have much of an appetite. And so I was like, oh, in the back of my head, appy workup. And so the resident went and saw that patient, came back and said, hey, I'm thinking about doing like an appy workup, and then they said, hey, there's a trauma coming. We need everybody in. It's a level 1, which means kind of more significant risk of injury. And so I said, just go do the appy workup, do ultrasound, CBC, CMP, lipase, get a urine, give them some pain meds, do a fluid bolus, NPO, and then we'll take it after the trauma. Ran into the trauma. It actually ended up being not too bad. I think that kiddo did fine. So maybe like half an hour, 45 minutes later, I came back out and I went, instead of talking to the resident again, I went straight into the exam room and I talked to the patient and I examined them, and they have a very classic exam for appendicitis. They're tender in the right lower quadrant. They're guarding, which means when I touch their belly, it gets kind of tense, like their muscles tense up. So I said, yeah, I'm a little bit concerned you have appendicitis. And he goes, it's really weird. This feels exactly like it felt before when I had appendicitis. And I was like, okay, what? He had appendicitis like a year ago and it was treated with surgery. And so the chance of him having appendicitis again is pretty low because he doesn't have an appendix. I went and found the resident and I was like, hey, this kid already has his appendix out. I think we could probably cancel the appendix ultrasound if he's already had his appendix out. And he's like, I thought about not doing it, but we were kind of busy. So he's like, I just put it in because you said so. And the ultrasound tech actually came out and said he has inflammation at the stump where the appendix was. He has stump appendicitis, which is a really pretty rare thing. It's the residual little like maybe bump or something that's there at the end of the kind of large intestine colon area. There can be a little ditzel of what's left of the appendix when it was removed. And he had inflammation and infection in that little ditzel, in the little stump. He had appendicitis. Appendix surgery used to be pretty invasive. They would cut open the abdomen like this, they would go in, they would clip off the appendix, but they're right there with their own hands doing it. Nowadays, we make small incisions around the belly button, go in with cameras and kind of small tools, and we're able to take off the appendix that way. Way less invasive, but there is the risk that you could leave a little bit more of a stump there with these tools and cameras than you would if you opened the abdomen. Even with the newer procedures making it slightly higher risk, this is still exceptionally rare, but something to keep in mind if you have a patient that has classic appendicitis symptoms and they've had their appendix out in the past.